Bismillah ar-Rahman ar-Rahim. My second talk today will be about physeal injuries and its sequelae and how to manage. We should think about what's different in pediatric fractures. When you're dealing with a pediatric fracture, of course, somebody will say that we have a very great healing power. We have soft bones that fractures very easily, but fortunately, the fractures are most commonly green stick fracture or buccal fracture or plastic deformation. But what is the most important difference between a child fracture and an adult fracture is the power of remodeling. And what do we mean by remodeling is that when the fracture unites, if the position is not 100% acceptable, during the coming years of growth, the child bone has the capability to remodel to a good position. If we have a flexion or extension deformity after fracture malunion, during the coming years, this deformity may remodel. The great power of remodeling is attributed to the physis, the physeal growth plate. But what happens if we have this physeal growth plate itself injured? What happens if the fracture affects the physeal growth plate? This may be something trivial, that the fractured growth plate will resume its function normally and the child will continue to grow and to remodel if there is deformity. And sometimes the physeal growth plate will be a catastrophe because the physis itself, which is the main cause of growth and the main cause of this remodeling, will reverse its function and it will be the deforming cause in the coming years. Second, we should know what affects the power of remodeling and what types of physeal injuries that we are going to talk today. The power of remodeling, which says that if we, as I said, if we have a fracture malunited in the upcoming years, it's supposed that this fracture may remodel to an anatomical position and the deformity is resolved. The main factor that determines the capability of remodeling is the age of the child. Of course, when we have an adolescent, his near growth will stop very soon, and that's why he's very prone to do internal fixation, while a child of 2 or 3 years, of course, has a very high capability of remodeling because he has something like 12 more years of remodeling, and that's why major deformities are acceptable and are supposed to remodel. The second point that affects the remodeling is which growth plate. As you all know, the main growth of the femur occurs through the distal femoral physis, and that's why if the injury or the deformity is near the distal femoral physis, anticipation of greater remodeling is anticipated. While if the injury is in the proximal femur, the remodeling power is lower. Also, if you look at the humerus, what we accept in the proximal humerus is something very great. We accept major deformities near the shoulder, while near the elbow there is very low power of remodeling, and that's why if we have a supracondylar fracture that ends up with mild cubitus varus, it's not anticipated that this will remodel because the distal humeral physis is a very weak growing physis. The third point is the distance of the deformity from the physis itself. The more the deformity is near the physis, the more the remodeling capability. And lastly, all of you know that we have a great capability to remodel the sagittal plane deformity, the flexion and extension, and less capability to remodel the varus and valgus, and very mild capability to remodel the rotational deformities. Here we start to talk about the physeal injuries. First, as you all know, the Salter-Harris classification. This is the Salter-Harris type 1, where we have the injury through the physis. There is no metaphyseal fracture. There is no epiphyseal fracture. And there is the Salter-Harris type 2, where we have a metaphyseal fragment with the physeal disc. We should separate between these. Type 1 and 2 are completely different from type 3 and 4. Why? You should all know that in type 1 and 2, the physeal disc itself, it's a disc that happens between the epiphysis and the metaphysis. Here and here, the disc is completely normal. It's not injury. The injury is above the epiphysis. It occurs either in the hypertrophic zone in type 1 and in the hypertrophic zone and with the metaphyseal fragment, the Thurston-Holden fragment. And the disc itself here is completely uninjured, and here also is uninjured. That's why formation of a bony bar between these two types, in these two types of injuries, is extremely rare. While in type 3 and 4 here, you find here in type 3, the injury in the epiphysis going up through the disc to the hypertrophic zone and passing through the germinal zone. That's why there is communication between the epiphyseal bone and the metaphyseal bone that happens through the disc. And if this, the fracture hematoma, may cause bone union between the epiphysis and the metaphysis, the so-called bony bar. And this is the main cause or the only cause of physeal growth arrest. Here in type 4, of course, it's more or less like in type 3. And in type 4, we have a metaphyseal fragment, epiphyseal fragment, and of course, complete disruption of the disc here. That's why a physeal bar or bone union between the epiphysis and the metaphysis may happen. Again, you should all know that when you have a physeal injury, the main or the only way to have physeal growth affection or arrest happens when you have communication between the epiphysis and the metaphysis through the physeal disc. Here the disc is completely uninterrupted, and that's why there is no communication between the epiphysis and the metaphysis. In type 2 here, the disc is normal with a metaphyseal fragment. In type 1, the disc is completely normal with no injury in the epiphysis or in the metaphysis. In type 3 and 4, the disc is injured itself, the disc itself is fractured, and there is communication between the epiphyseal bone and the metaphysis. And here, between the epiphyseal bone again and the metaphysis, that's why a bony bar may happen. Okay, this is an X-ray of the distal femoral tibial physis, where here you can see there is a Salter-Harris type 1 injury. Here is Salter-Harris type 2 with a Thurston-Holden fragment, and the periosteum is supposed to be injured on this side. This is very important to know. The periosteum is injured on the other side of the metaphyseal fragment. If the reduction is not anatomically reduced and you need to do open reduction, you should open on the contralateral side of the metaphyseal fragment. Here in type 3, the epiphysis is broken, and of course, when we see this, we know that the disc itself, which we do not see on the X-ray, but here we know that the disc is already injured. In type 4, of course, the disc is injured. The frequency of the physeal injuries, fortunately, we have type 1 and 2 compromises about 3/4 of the fractures, and type 3 and 4 and 5 comprises only 1/4 of the fractures. Here it's type 1. We have the disc, as I said, it's not injured. It occurs through the zone of hypertrophy. When we have it, it's either non-displaced, it's not diagnosed with an X-ray, the X-ray is normal, we have only localized tendons, normal radiographs, and the management is only casting. We call this a Physeal strain. When you have displacement, the examination is, we have a deformity, the displacement is seen on radiographs, we do closed reduction and casting. Sometimes we need to add K-wire fixation like in the distal femoral physeal injuries, even if it's type 1. In Salter-Harris type 2, as I said again, the physis is completely normal, it's not injured, but the injury occurs through the hypertrophic zone, and we have the Thurston-Holden metaphyseal fragment here, and as I said, this is the site where the periosteum is injured. The management is closed reduction and casting. We may need, as I said, percutaneous or screw fixation in the distal femoral physeal injury, because this is a physis that had bad reputation of physeal growth arrest. In type 3, we have the epiphyseal fracture. This is the epiphyseal fracture, and the physeal disc is broken, and this fracture passes through the hypertrophic, proliferative, and the germinal zones. That's why we should anatomically reduce the disc to close the space of the physeal disc injury to prevent the occurrence of the bony bar. This is done When we have this fracture, we should do proper X-ray and CT to evaluate the gap in the physeal disc. If we find this gap more than 1 millimeter, closed or open reduction should be done and screw fixation to compress the fragments to prevent communication of the epiphysis and the metaphysis and the formation of the bony bar. In type 4, it's managed like in type 3. We should do anatomical reduction if the gap is more than 1 millimeter and screw fixation. Of course, we should try not to pass these screws through the disc itself, but we can pass K-wires, smooth K-wires across the disc. Salter-Rice type injury is a crash injury. That's why it's managed conservatively. But later on, we find the physeal growth arrest and the deformity will happen. Okay, again, what happens when we have physeal growth plate injury? As I said, in type 1 and 2, it's assumed that you will have no deformity. The physeal growth will resume its function normally after that. But if the physeal growth arrest happens like in type 3 and 4, we should anticipate that this physeal growth arrest is either complete growth arrest, like in type 5, or in type 3 and 4, when there is a major injury, it's complete growth arrest, or partial growth arrest that will cause both angular deformity. If it is a peripheral bony bar that happens, when the bony bar is in the periphery, it causes deformity. If it's central, it acts like the complete growth arrest and it stops the growth. Okay, how to follow up a case of physeal growth arrest, a physeal growth injury. How to follow up? We should follow it looking at the normal physeal contour. Here we have a normal physeal contour, and here we have transverse Park-Harris lines. These are the lines which are transverse, parallel, seen here and here, which says that the growth of the physis is normal. But when we have loss of the normal physeal contour with sharp defined connection between the epiphysis and the metaphysis, when we have tapering of the Harris-Ross lines, or lastly, we can have the deformity or the growth arrest and shortening. Here, after 6 to 12 weeks after the fracture, you can see the Harris lines converging to this bony bar, and of course, later on, you will find a deformity. When you have this bony bar posteriorly, the growth will continue anteriorly and a flexion deformity will develop. This bony bar, if it happens, when we should do proper mapping, and we should know the topography of the exact site and the extent of the bony bar. This is done through CT and MRI. What to do when you have a physeal bony bar? It depends on many factors. First, the patient age and the growth remaining. If the patient age is just near skeletal maturity and the remaining growth time is less than 2 years, it doesn't matter. And also, which physis is affected. If it is the proximal femoral physis, the problem is so minor in comparison to the distal femoral physis, which is a very important physis. When you have the physis, a main growing physis like the distal femur or proximal tibia, the concern is so great. While if the injury is in the proximal femur, it's a problem, but not a great problem. Also, the extent of the bony bar or the affection of the bony disc is less than 50%, but now what is more appropriate and more acceptable in most of the literature is only 30%. When the injury is less than 30%, this injury is supposed to be repairable. But if it's more than 30%, then this bony bar is irresectable. Also, the location of the bar. The central bars has better reputation when you resect it than the peripheral bars. If the central bar is less than 30% and you go on for resection and you have more than 2 years of growth, it's anticipated that this physeal disc may function again normally. Okay, in case of complete physeal growth, or if the physeal growth is incomplete but more than 30%, these cases are managed according to the problem. If the limb length inequality is minor when you have this problem occurring just before skeletal maturity, it needs no treatment or maybe just a show lift. If the shortening is more than 2 centimeters, we can do contralateral epiphysiodesis or one or multiple lengthenings or combination of the above. Okay, when you have partial growth arrest, what to do? This is very important to understand. If the physeal growth arrest is less than 30% and you have more than 2 years remaining of growth, then we should go for bar resection and interposition to resume the function of the bony bar, of the physis again. But if the injury is more than 30%, we should complete the physeal arrest of the whole plate. These are after proper mapping with a CT or MRI. We here have a peripheral bony bar, which is of course less than 30%. Here is less than 30% central bony bar, and here is a linear bony bar. Okay. For peripheral bars, it's simply we go directly to this is the metaphysis and this is the epiphysis. This is the bony bar and this is the normal physis. We should resect this bony bar, peripheral bony bar directly, and we interpose here a fat pad to prevent reformation of the bone again, and we can put radio markers to follow up the case after that. When you have a central bony bar, again, if it's less than 30%, we should go through a metaphyseal window and curette the bony bar totally. Be sure after proper mapping of removal of this bony bar, this is the bony continuity here, and then we interpose a fat pad and put radio markers to follow up the growth. Here's a case of a Salter-Harris type 3 of the distal tibial physis. An anterior bony bar happened. We should go for removal of the bony bar with a curette and the interposition of a fat, and these are the radio markers to follow up the growth after that. Again, this is a case of a proximal tibial physeal injury. It's central but a bit anterior. It caused tethering here of the growth. That's why you see reversal of the slope of the proximal tibia. Here through a cannulated reamer and going through the metaphysis, we opened a space here, and then through the curette we are sure that we removed all of the bony bar and we put fat on assumption that the physeal disc will regain its function again. Okay,